Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director for Clinical Education and Partnerships with SICA, where we partner with healthcare providers to offer body composition solutions. So today I'm joined by my favorite obesity care advocate and blogger, pharmacist, and all around incredible person, Ted Kyle. And if you don't know about Ted and his blog, ConcienHealth, you are missing out. Ted keeps us all up to speed on what's going on in the news, in the media, research, and really everything as it relates to health and weight and obesity. Ted and I have been on the board of the Obesity Action Coalition, and actually Ted was the person who asked me to be on that board. So thank you, Ted. I'm never leaving. I love the OAC community. It's been a really rewarding part of my career. So I had to have you on today to talk to us about the new Lancet report on the diagnosis of clinical obesity. And I thought we could chat and kind of go back and forth about some of the stuff that's in there.
Very cool. I am very excited to be here and very excited about this report because I think if it is not the most important milestone of this year in obesity, it will be one of a very few important milestones. We'll wait and see what else happens, but I know that this is big and it's going to shape things for years to come.
Absolutely. So if you don't know what we're talking about, the Lancet Diabetes and Endocrinology Commission has introduced this landmark framework for defining and diagnosing obesity. And they really are advocating for a more nuanced or evidence-based approach. And this report really does redefine clinical obesity. So we're going to talk through what that means. And it does emphasize the characterization as a chronic systemic illness driven by excess adiposity and the impact on organ and tissue function. So these are all key components of what they defined here. So Ted, you weren't part of the commissioners for once. But I know that we collectively know a good bit of the folks that were on this group. So can you talk to us a little bit about, how this came about and how they did the way that they came up with some of these recommendations?
Well, it's been a long process. The initial thoughts about forming this commission surfaced 5 years ago. The commission has actively been working for more than 2 years on coming up with these recommendations, and it's been a consensus process with people from all over the world trying to build a consensus. And consensus is a really difficult thing, particularly if you want to come out with something that is a real advance, because people take time to wrap their heads around something that is as nuanced and important as a definition of clinical obesity. Why is this important? It's important because until now we've been defining obesity more as a risk for disease and harm to health based upon BMI than we have been really distinguishing the clinical condition of obesity, which is actually impaired health because of excess adiposity. And having this definition, I think, will be transformational. The transformation will not occur overnight. It will take time, but as time goes by, the compelling logic of this definition will be unmistakable.
I really appreciate sort of that distinction between risk, and that was something in the report. And when they did their global launch earlier this month, I think that was a really important distinction where they're talking about, we're talking about clinical diagnosis means you have this in the here and now. So it's not about the likelihood of it happening or the, potential, but we've got to tackle, this feeds into treatment then, right? So I know
Right?
we've talked a lot about prevention and treatment and management, and there's now kind of a place for the prevention side in that preclinical obesity, or that uncertain place of, someone who has, markers maybe, but not that disease or illness or organ function, kind of impact yet. But the folks who have that clinical diagnosis, this is really where we're wanting to link that to treatment, and support from then policy and insurance and reimbursement and all of that.
Absolutely.
So a little bit more about that clinical diagnosis. Can you talk us through sort of where they landed with what is clinical obesity and what is preclinical obesity?
So it's really a sort of a two-step process of, first of all, defining whether or not a person has excess adiposity. So when you started out, you said that obesity is a chronic disease driven by excess adiposity. The first step in defining clinical obesity is to define what it takes for someone to be regarded as having excess adiposity. And so the first big milestone or the first big determination was that BMI by itself is not adequate for determining that someone has excess adiposity, and BMI alone should not be used for anything other than screening or epidemiology. Okay, so it's okay for screening, and it's okay for trying to figure out what's the proportion of the population that may have obesity. But so far as looking at an individual and determining that they have clinical obesity by itself, it is not enough. And that means you have to look deeper. You have to look at body composition. You might need to look at waist circumference or some other indicator to say, yes, this person has a high BMI, and that high BMI is evidence that they have excess adiposity as corroborated by these other clinical measures of their adiposity, their body composition. So that's the first thing. Does this person have excess adiposity? Then the second thing is that excess adiposity manifesting as a clinical illness? Or do they have excess adiposity that is not causing any illness? And so if they have excess adiposity that is not causing any illness, then according to the schema of this commission, then they have preclinical obesity. This makes perfect sense to me. If they are manifesting clinical illness, then they have clinical obesity. So it's really those two things: excess adiposity and the presence of clinical illness. And then if you look at the report, there's like 18 criteria for adults and a similar number of criteria for children and youth.
Right.
That verifies that there is the presence of clinical obesity.
So, yeah, I think that kind of the language that I picked up on too is that clinical confirmation of excess body fat. I think that's where,
Yep.
we know that we've been seeing a change in clinical practice over the past few years where more and more providers are kind of taking that more nuanced approach. I really
Right.
like how much the word nuanced has been
Right.
used in association with all this, because that's what I really feel like prior has not been appreciated. And
Right.
so that, the idea that using other metrics, right? I also picked up on a whole lot of this global nature and kind of initially, I think that the core goal of this group was to talk about a global focus for even like rural and low income um, countries. So how do they add some of this? And so I
Right.
think that's where we're really looking at that waist circumference as another measure of looking at someone's body size and shape
Mm-hmm.
in a place where they can't probably go much deeper. But
Right.
here in the U.S. and probably some other places around the world, we may be able to go directly for that more direct measure, and that's, for me, where our body composition or our bioimpedance analysis comes in, because we're not even talking about, a referral to go get a DEXA to look at bone density and maybe excess adiposity. But with bioimpedance, we're actually also getting it right there in the clinic. It's quick, it's easy, but we're also being able to look at skeletal muscle. And that's a big
Right.
component when we start to add the treatment layer of looking at some of the medications or surgical or even lifestyle interventions, we're starting to want to look not just at the adiposity, but at that whole picture. And so we do have muscle mass and some other metrics that we can start to look at. So I'm
Right.
excited that we're going to start seeing more providers really going deeper, because even though our culture and our language has changed over the past couple years, I feel like a lot of providers are saying more than weight, more than obesity. But then you go to that clinic, and what are they measuring? Just weight, just BMI. And maybe not even looking at some of those additional health conditions that you're talking about, or signs and symptoms that we can connect to that. So I think
Right.
it's going to change practice.
I do too. I
And
agree
like
with
you
you
said, maybe
totally.
not tomorrow.
It takes time for people to change their ideas about how to look at something as nuanced as obesity. And yet, the response to this, in my view, has been very positive because people look at it and say that the top line message here is that BMI alone is not enough. And for example, any number of thought leaders have said, well, yes, of course, um, that is obvious. We've been saying that for some time. Thank goodness this is being recognized. Absolutely. We need to go deeper. We need to look at body composition. People are ready to embrace this. And at the same time, it's a big change in thinking. So other people hear it and they say, I don't know if I'm ready for that.
Yeah, it's I think it'll be easier for people to embrace that too, now that there's some like real consensus and support too. Your
Right,
early adopters were doing it because it was the right thing to do, because they understood how that could impact their counseling, or that they could help their patients with their outcomes. But now we're beyond the early adopters to saying, okay, we're actually going to sort of change the practice. And along with the AMA kind of moving in this direction, it does sort
right.
of feel like we're kind of reaching that point where this can start to be part of what we all do.
It's also important to note that this consensus recommendation has the endorsement of an amazing breadth of organizations ranging from World Obesity to the Obesity Society to ASMBS, and then on to organizations like American Diabetes and
Mm.
American Heart. And getting that kind of endorsement should have been like a 10-year effort. And the group that was this commission made it happen in just a short time. Really, I'm in awe of this
Yeah,
accomplishment.
that's a good point. Another point kind of in that same area is that the way they did the consensus, they show you the percent of that we're in agreement. And I
Right,
guess everything on here is over 90% is
right,
an A, and then everything that was unanimous was a U. That's 100%. And so many of these statements had 100% of the commissioners, or the folks who were on here as experts, agreeing with that from their evidence based or evidence backed approach. And that's a big deal.
yeah.
I've been in a lot of rooms with a lot of, probably some of these people, and to get everybody to agree to some of these statements, the semantics and all of that definitely would take a long time. And so, like you said, even though it's taken a couple years, that's actually a short period of time to get something this strong.
Sure enough, couldn't agree more.
So another thing I thought we might be able to talk about, of course, you and I are very strong advocates for the patient. And so I really also appreciated that they considered the patient approach, those who have the lived experience. We think more and more this is becoming, again, standard of practice to have the people that we're aiming to treat as part of the conversation. And so they had a couple patients on as commissioners. They had a patient voice, talking about this at the global launch yesterday. And how are patients reacting to this? Have you had any insight there?
Well, you might have as much or more insight than I do, but I think broadly people are saying yes. This is a good step forward because it recognizes that obesity is about health, not size. or BMI alone. Um, and then there is some nervousness,
Mm.
and the most frank expression of that nervousness is a question that it raises. Will people use this preclinical criterion to exclude people from getting coverage under their health plan for treatment for obesity? Does this mean that people who have preclinical obesity don't get treatment, and people who do have clinical obesity do get it?
Mm.
Does that create a case of the haves and have-nots? Now, if you read the report, they talk about the need for treatment in both of those groups, which I think is good. And so this is something that I recognize is a valid concern. But then at a higher level, I would say that I have the reaction of, you know what, to think that health plans and pharmacy benefit managers will start making it difficult for patients to get access to care is kind of absurd, because I don't know how it could be any worse.
Yeah.
Better than 90% of people with obesity do not get evidence-based care, and a large part of that is the barriers that health plans erect. So, is it going to get harder? I think not. And in fact, I would argue that having objective criteria makes it easier to make the case for more people to get care.
That's a good point. Yeah, almost like how's it working out for us now? Right now, it's not like you said. 90% of people who need treatment aren't getting it. So
Yep,
let's try something different. And I totally see that.
yep.
Um, there's also a part in there that we haven't talked about yet, where they're kind of considering folks with a BMI over 40, almost assuming that they have excess adiposity. And I wonder how that's kind of going to land with both patients and with policy as well. Do you have any thoughts on that?
So I think that it's kind of obvious that you don't need a secondary confirmation of excess adiposity if somebody has a BMI over 40. So I think that part of it makes sense. I have heard clinicians say that so they're saying that BMI is not good enough if your BMI is less than 40, and uh, And my reaction to that is no, that's not what they're saying. They're saying that in that range below 40, if you want to know if someone has adiposity that is excessive, then you need to understand their body composition. And I think that's perfectly reasonable.
Yeah.
But not everybody agrees with that. A lot of people who are used to this easy peasy uh, threshold of if you have a BMI over 30, then you have excess adiposity and obesity. Don't want to let go of that. Uh, and I would simply say that ship has already sailed.
Mm.
People are already out there saying that BMI is not a cut and dried measure of whether or not someone has obesity, whether or not someone has excessive adiposity. It has limitations, and what these people on this commission have said is that one of the limitations is that you can't rely on it with a BMI under 40 to tell
Yeah.
you that this person has excess adiposity that is a health problem. You have to look harder.
And I
It's
think
okay for a
even
screen, you just have to look harder.
even thinking about the math of it, right? Like if you looked at how many people over BMI over 40 had excess adiposity, it would probably be most. And so it's almost, actually, I hadn't thought about it like this before, but it's almost like taking a little bit off of the clinician to then say you don't have to do all these additional measures just to treat that patient. So that's an easier way for a patient with a BMI over 40 to get into treatment.
Right.
And then, the other part is, for the longest amount of time when I worked in bariatric surgery, we had the under BMI under 40, we would call it the treatment gap. right? Where we
Right.
had diet,
Right.
exercise, lifestyle for
Right.
up to, BMI of 30 or
Right.
obesity categorization back then.
Right.
And over 40 was surgery. But anyone
Right.
between 30 and 40 had really no good options. And so I think that's been probably the most revolutionary, you know, it- over the past couple of years is like we now have treatment options for people in that category, but how do we figure out how to help people in that
Yep.
treatment gap? So this helps
Absolutely.
that.
Yep. I agree completely. I
And I
agree
see that
completely.
with body composition reports, all the time, where we have people who, if you just looked at BMI, I see both sides. Someone who's got a BMI of 23 and at 45, 50% body fat,
Right.
where prior we would say, oh, you're fine, you don't need any treatment, keep doing what you're doing with a BMI
Right.
of 23. And now we're saying, wow, okay, that person's body composition now puts them in a category where they need additional treatment. And so maybe we don't classify everybody or do that confirmation once their BMI is higher, but that's just the starting point. I mean, I
Yep.
think the
Yep.
other part of all of this is just getting in the door, right? Once somebody's
Right.
in a clinic and gets their body comp done, gets their treatment plan, gets their
Right.
approach from their, team, we're going to be monitoring them for life, hopefully, because it is a chronic relapsing condition. And so
Right.
this helps give data as they're changing their health and their body size and their body composition to be able to kind of check in and keep them on the plan.
Absolutely. The other thing that I think is worth mentioning is that this is not to say that it's not worth looking at body composition if a person's BMI is over 40. This is simply saying that to establish the clinical fact of excess adiposity, that additional step is not necessary. To establish the diagnosis, it is not necessary. But there's every reason in the world, once you make a decision that the condition is present, there's every reason in the world to say, maybe I need to look deeper and understand body composition to understand this person's clinical status. And that's
Totally.
perfectly reasonable.
And as that person's changing, we know for motivation, it's nice to have metrics along the way. So,
You
how
bet.
nice for that person to, when they get under that categorization, and then when they get to a certain
Yep.
point for, body fat percentage, or, some of these other metrics are really nice to keep people motivated and on the path when they're in that treatment phase.
Right. Right.
Yeah, it's, again, you're bringing up all good points. I hadn't thought too much about the fact that this is really just the almost like the minimum viable product to get you into care. And
Right.
none of this document has to do with what happens once you get there, right? So it's really, we do need to remember that we're not here posing treatment options or pathways or comprehensive care. We have lots of other documents in this space to talk about that. This is just who goes where and how do we get them to the right people to help care for them.
That is exactly right. This is not a clinical care guidance. This is a diagnosis guidance. This is guidance for the clinical diagnosis of obesity. Staging and treatment is a whole different thing.
And we haven't really had that before.
Right. That's right. We've said that obesity is a disease, but in fact, the criteria have defined it more as a risk factor. No wonder people are confused or have been confused. I
Right.
think clarity will come from this.
I've kind of been thinking about it like we're talking about both objective yet understanding the nuance. We're talking about risk reduction and that therapeutic intent for those who have that clinical diagnosis. And then we're also really talking about screening versus diagnosis and that preclinical versus clinical. So I think there's a lot of things to dive into in thinking about how this is going to change an individual's practice. And I know for me, talking to providers about health and weight and obesity, I think this is going to inform a lot of that care.
Mhm.
So in a clinic setting, how do you see providers sort of taking this and operationalizing it?
Well, I think will take some time for people to incorporate in this into their regular flow of clinical care. And how that happens is going to differ depending upon whether you're talking about somebody who is an obesity medicine specialist who's already doing much of this, or someone who is in primary care and will, maybe not overnight, but over time, come to recognize that if I want to provide care for the patients in my practice who have obesity, excuse me, I need to do more than just take their BMI.
Yeah, you're right. The specialists are doing this. The obesity medicine teams and the ABOM certified doctors, they have comprehensive care. So this is just support for what they're doing. But yeah, I think getting the word out about this to our primary care colleagues and to folks who are in, other areas that they don't know all the, nuance to the obesity treatment. I think you're right. That's where we've got to spend probably some of our education and our advocacy efforts.
Absolutely.
Making sure they know how to do a waist circumference and making sure that they know, where and how to get those additional sort of confirmation of excess body fat metrics and how to do that
Right.
in practice.
Right. And this is something that was in progress anyway. There is a clear recognition that primary care needs to be equipped to provide care and appropriate referrals for obesity care. And this just gives us one more tool for equipping people for that task, because the very first step is to say, do I have a clinical condition that needs care, or do I have a preclinical condition that is a risk factor for future problems?
That needs surveillance and monitoring.
Yeah, surveillance, monitoring, and certainly possibly treatment, depending upon the circumstance of the patient.
Yeah, I saw somebody had written it. It may have been in your blog, where they had written about what do we do for the folks in the preclinical condition, and just like you would with another health condition, maybe high blood pressure, right? Someone who has pre-hypertension or pre-diabetes. We don't just say go away and wait until you get that condition. There's specific lifestyle, behavioral, maybe medical interventions that we do for them, people who want to not get to that next clinical.
Exactly.
So Ted, one of the things I think we've heard a little bit about is if we're putting someone in this preclinical obesity category, is that going to exclude them from care, even if they have a much higher BMI or weight and high body fat percentage, but they don't have one of those sort of 18 diagnostic criterion as listed in that paper?
So I would say two things along those lines that I have heard and I have thought about a lot. And one of those things is, of course, what we just talked about, which is, if you have preclinical obesity, does that mean that you don't get any kind of treatment? And the guidelines specifically say that treatment is appropriate or can be appropriate, including things beyond lifestyle interventions, even if someone does not have clinical obesity. And this depends upon factors that they describe quite well. But then there's this presumption that in order to have clinical obesity, this may be saying that you have to have medical symptoms, physical symptoms of obesity, like cardiovascular disease or liver disease or joint disease or something like that. What about somebody with a BMI of 40 that has excess adiposity but is not having medical complications of obesity? And there I would direct people to look at that criteria number 18. Are they experiencing limitations of daily life, impairment of their quality of life because of obesity? And I would say that there may be people who have a high BMI and have minimal impairment of daily life because of it. But I would also say that those people are very, very uncommon. And I think that criterion takes into account the lived experiences of many, many people. And I commend the commission for including that as a
Absolutely.
criterion for diagnosis.
Yes, absolutely. So, here it says significant age adjusted limitations of mobility and other basic activities of daily living. So it's a pretty broad category for some of the, you know, I would say really impactful life altering things that
You
impact
bet.
someone's day. And to me, that area actually, when I worked with patients who had severe obesity, that was an area that the functional improvements they had from even a small amount of weight loss was so impactful on their life. And
Exactly right.
that functional piece where it's, how are they interacting and moving about in the world? And we talk about that even with physical activity and movement and exercise. That's a big limitation until we get to a certain place. And so that's, I think, a really important area that providers take and don't just take that just to critically really get the story and the history of the patient and figure out how that could be a factor, and that they're calling that diagnostic is very impactful. You're right.
I think so. And it reflects the wise choice to involve um, people who represent the lived experience with obesity and include in their report the impact of bias and stigma with the disease of obesity.
Totally. I was happy to see that as a focus and mention, and more than just even a mention in the paper
Yes,
as we're talking about diagnosis, and not even yet really the treatment, it's or the clinical guidelines, but in the diagnosis, understanding
absolutely.
how bias and stigma has impacted that's pretty big.
Yep. Okay.
Well, what else? What do we need to sort of make sure that the takeaways are for people who've either read and haven't yet digested, or don't have the bandwidth to get through this big paper?
I think the big thing is to keep it at that 30,000-foot level. This is really all about formalizing what we've known all along, that obesity is about health and not size. And and people need to accept the fact that this is a big change that will take the medical system, healthcare providers broadly, time to digest and internalize and operationalize. And if we're saying we need to get beyond BMI, then I think for the good work that you do on helping people understand body composition, that just becomes all the more important.
Yeah. I know I'm thrilled that we're moving beyond that, as I've said, for years in the surgical world, there wasn't a lot of change. And in the past 4 or 5 years, we've seen a lot of
Yep.
movement,
Yep.
but we've still seen a lot of, people saying, hey, beyond BMI, it's not just weight, it's not just BMI. And they're not doing anything more than that at the clinical practice level. And so I think this is, again, that push to do it. And so supporting what those early adopters have really been able to show the impact of how that, helps them do their work and the comprehensive care. And then for the patient experience as well. It's very exciting.
Absolutely right.
So, well, thanks, Ted. As always, I appreciate you, early adopter as you are, talking to me about this. And if you're not following Ted on all the social media, ConcienHealth is where you need to be for all things obesity care.
Thank you so much.
Thanks, Ted.
Take care.